I'm now going to hand over, and delighted that we have Mandy Rayani, who's the Executive Director of Nursing for Quality and Patient Experience at Haldar University Health Board. And Mandy is going to give us an introduction to the session and the speakers that we have today. So I shall hand over to Mandy. Thank you very much.
That's lovely, Martine, and I just hope I do this right. So welcome everybody to this online masterclass, which is focused on behaviour change in practice to support reducing nosocomial transmission of COVID-19, a topic we have lived and breathed for the last, well, almost year now. So this is an interactive session, but as Martina said, please put questions in the sidebar, because with so many people on the call, it's often can become a little bit chaotic. And during this session, you're going to be able to have the opportunity to explore a wide range of factors that influence our day-to-day clinical practice behaviours. And then from this, an approach that will be about selecting techniques that most effectively support optimum practice. The barriers to correct use of PPE in particular will be explored as a practical example during this session. And for those of you that don't know me, I also have the pleasure of being the chair of the HCAI Delivery Board in Wales and working on with a really great group of people, expert in the field, around developing infection prevention control standards and also cleaning standards for Wales as well. And all of this is relevant when we're looking at how we change practice and some of the behaviours that help us to change that practice on a day-to-day basis in what we know are very, very busy lives that we all lead. So it's my pleasure really to introduce the speakers today. Dr. Judith Dyson, general and mental health nurse and chartered health psychologist and reader in healthcare research and implementation science at Birmingham University and the Improvement Academy behaviour change specialist. I hope you managed to carry your very heavy badge around without injuring yourself, because that is quite a title. But welcome and thank you for taking the time to be here with us today. And also Liz Watson, Programme Manager and Improvement Coach with Improvement Academy. So welcome, thank you. The session is also supported by Gail Lusardi, Consultant Nurse, and Amanda Daniel, IP&C Lead for Community and Primary Care, Healthcare Associated Infection and Antimicrobial Resistance Programme. And they're both based in Public Health Wales. And then, of course, to Martine Price, who's just introduced herself, and Lisa Fab, both of whom are with Improvement Cymru. So I'd really like to take this opportunity of thanking you for taking time out of what is, I know, an extremely busy schedule. But I do hope that you find this hour-long session practical and helpful in how you go about undertaking your day-to-day work. There will be resources shared with you following this session, and hopefully this session will spark your interest to go on and register for an event that's a short online interactive course. And now it's my pleasure to hand over to Liz. Please enjoy. I know I will. Oh, you're on mute, Liz.
Can you hear me now?
Yep.
Oh, that's good. I've been having problems with my mic just recently. So thank you, Mandy. Hi, everybody. Welcome to our session. Can you just go on to the first slide, please?
Oh yeah. Can you see the slides, Liz?
So I won't go over housekeeping again, but just some introductions to behaviour change. On this slide, we have a picture of our website, and at the bottom, we have a really great video that really nicely summarises everything that we're going to introduce you to today. It's well worth a watch, and especially if you've got any colleagues that might be interested too, you know, you could signpost them here. And then also on this page, at the top corner, there is also a link to our behaviour change toolkit. The toolkit is completely free and it is able to download all the resources from it, and it takes you through a step-by-step process for behaviour change projects. And you'll find a link to this page at the very end of this presentation in our references slide. And then finally, I wanted to let you know about the fact that we're going to be asking you to do some pledges this afternoon when we finish. So what we're going to be asking you to do is to think about what are you going to do when you get back into practice to improve PPE use. So as we go through the session, just have a think about it, and hopefully we'll give you plenty of ideas to be having a go with. We can move to our next slide and we get started on our first exercise. So what I'd like you to do is to just everybody to have a think about what are the barriers that you and your colleagues encounter when it comes to using PPE. And I'd like you to identify as many as you can. We're going to set a 2-minute timer, and I'd like you just to pop all of your answers into the chat. It'd be really great if everybody could at least pop one in, but you can pop as many in as you'd like. So just think about the things that that get in the way. What are the barriers? What problems, have there been any specific problems that you've encountered before when you've been using PPE? Is it easy to know which PPE to use? There we go. I'm getting I didn't think it was working then. I wasn't getting anything through on the chat, but it's coming through. So I've got people saying that it's cumbersome. It's you're thinking about comfort and fit. What about how do you feel when you're using PPE? Does it make you feel tired, frustrated? Do you feel safer? Are you supported by your peers to be able to use PPE? Do you feel you could challenge people if they're not using it properly? Are there any other priorities that might get in the way of you using the right PPE? So difficulties with communicating with people is coming up on the chat. Lack of time. Other people can be dismissive. That's interesting. So we've got lots of different barriers coming up. Access to the correct PPE can be an issue. Oh, this is absolutely brilliant. Okay, so you can keep on putting things in, and what we'll do is we'll move on to the next bit, and I'll pass you over to Judith.
That was brilliant. I think this is one of the really nice things about Teams. Liz, can you go on mute, please? I'm getting some feedback. We get the chance to type so many things so quickly and capture it as well to take away afterwards. That was fabulous. On this slide, this is one that we prepared earlier. Both Liz and I are engaged in other work about PPE and looking at barriers more generally with other practices. And you can see a lot of the things that have come up in the chat are also on this slide here. We are going to come back to the barriers that you've brought up by way of examples as we go through this session. So there's a few points that we wanted to make about the barriers, really. So I think the first thing that we need to say is there are lots of barriers coming up in the chat, and there's lots of barriers that are illustrated here. Now, when you work in a particular environment, a single environment, usually when we're looking at barriers to practice, we'll get maybe three maximum that are big barriers and lots of little ones. So I know, having looked at the delegate list, and we've got nearly 100 people that have joined us today, there are people that are working in care homes, people that are working in ICU, being specialists in infection prevention, working in A&E, all over the place. The barriers will be different from place to place to place. This range of barriers that you've given us and that we've put up here is absolutely fact across a whole wide load of different places, but probably in your own environment there'll be maybe 2 or 3 top barriers. So having freaked everybody out with this massive list of barriers, we're just trying to kind of put in that little bit of reassurance for now. And the second thing to say about this is that time always comes up It always comes up as a first barrier, and we're going to come back to this in a little while. And for me, I wish there were as many different words to explain time as there are for snow in Iceland, because time can mean a lot of different things. And if somebody's talking about time when it comes to barriers, I guess the advice that we're giving just now is ask more questions. There's always more to it. And it's a piece of work that I'm doing at the moment with York about news, and it's about doing OBS. And between 6 and 7:30 in the morning, they've got the OBS to do, they've got handover to do, they've got meds to give out, breakfasts to sort out where needed, people to help get dressed and get out of bed, and they're supposed to do the OBS as well. And for some reason, we do everything on the even hours in York rather than at 9 o'clock. So time is a really difficult one, and it's always worth mentioning specifically. It's really complex. Now, interestingly, when we ask people what sorts of strategies are taken to address all of these barriers, they tend to tell us that it's things like workshops, educational events, protocols, emails, those sorts of things. And what we're hoping to do today, and we've only got an hour, and it's really hard to do in an hour, but hopefully we'll just be able to say enough to inspire people to think just slightly differently. So that's all we're really aiming to achieve today. So let me move on to the next slide. So when it comes to improving practice, or getting evidence into practice, I mean, first of all, from research to practice, it takes still on average 17 years. So from once we've got that conclusive evidence to it being embedded in practice, we're talking 17 years. Around the mid-2000s, a lot of researchers have put a lot of effort into researching and systematically reviewing the reasons why we don't always adopt optimal practice, whatever that practice is. And if we look at recent systematic reviews, and any references we don't give, feel free to email us, and we'll let you have these papers. Still at the moment, in recent systematic reviews, we healthcare practitioners adopt optimal practice around 50% of the time. So that's very much across all healthcare practitioners, across all practices. So some we're better at and we adopt more consistently, and some we're not as good at. I do a lot of work with infection prevention and hand hygiene in particular, and I know our audits say 90+%, but when we measure compliance under proper controlled conditions, we're still looking at 65 to 68% compliance. And the reasons for that is not because as healthcare practitioners we don't want to do a good job or we don't care about patients. We do, and we all come into this profession to make things better, to help people. It's because of all of the things that you guys have just put in the chat box, all of those things that get in our way. When we talk about behaviour change, that can sound a little bit personal because behaviour sounds like bad behaviour or something that's a little bit to be criticised for. But actually, when we're talking about changing or supporting behaviours, we're actually talking about influencing the determinants of behaviour, or put differently, all those things that get in our way, all of those barriers that you've just listed. So when we're talking about behaviour change, we're talking about giving us a clear street to get on with our jobs, addressing some of those barriers so that we can do better. So going back to what I just said a moment ago, when it came to about 2005 and lots of research looking at what strategies help us in practice to adopt best practice. And I think one of the latest big ones was Jeremy Grimshaw, and his conclusion, as were many others before him, there are no magic bullets. So things like educational meetings, audit and feedback, reminder systems, computerized prompts, all of those things that we put in place to help us. Some things help us sometimes in some environments, for some people, in some contexts sometimes. The reason that they don't work all the time for all people is because of these things. We need to assess what the barriers are in each individual unit because they differ according to where we're working in a whole range of different factors. So the three things that we need to think about to improve practice is that we need to assess those individual barriers and facilitators, or the determinants, to best practice. We need to tailor our strategies according to best practice, according to those barriers, and we need to use a theoretical approach to assess the barriers and to underpin our strategies or interventions to improve practice. So what I'm going to try and do on the next slide is demonstrate that rather than talking about a whole lot of theory. Here we go. So we've delivered a lot of full-day workshops with over 2,000 healthcare practitioners across the UK and also in various other countries. And when we ask people about the barriers to their health behaviours, these are some of the things they say. I've just realised I've got two screens, so sometimes I'm not looking at you. I'm really sorry about that. I'm looking at my other screen. I'm not distracted, I promise. So they say things like, we don't enjoy it, or you know, we don't like going to the gym. I always say I look absolutely terrible in lycra. It definitely does not suit my bum, so that stops me going to the gym. We're not motivated. When we ask about our patients' concordance behaviour, why our patients don't always, for example, apply their eczema medication or take the tablets that are prescribed for them, or they don't engage in some of the things we ask them to do that are best for them, and we ask practitioners, they say things like their patients don't understand the benefits, or they think they know better, or they don't know how to do it. And then when we ask people about their practice behaviours, they say some of these things and some of the things that you said too, time, staffing levels, resources, forget, the consultant tells me to. Now, interestingly, all of these barriers are true of all of these and any other behaviour, depending on the context, the environment, various other factors. So all of these can be true of, say, applying PPE, depending where we work. So when we are asked about our practice behaviours, it's really difficult to say, I can't be bothered. Why don't you put PPE on? Because I can't be bothered. Now, most of the time, that, as I've put it, probably isn't the case, but it's really difficult for people to talk about lack of motivation, or, oh, I'm getting some things here that people can't see the slides. So what I'm just going to do is I'm going to pull the slides off and put them back on again. I'm sorry about that. And I'll keep talking while I'm doing that. Oh, some people can see them. Slides are on the screen here. Okay, well, I'll make sure that I explain everything that's on these slides, and you will get the slides afterwards. So the first point that I'm trying to make here is we are stressed at work sometimes. Sometimes we are burnt out. Sometimes we don't like what we have to do at work. It's probably not our favourite job, cleaning up after somebody that's been incontinent. We do it because we feel for that patient, for that other human being, not because it's something that's necessarily a delightful task for us or it's our favourite job. But some of those things are very difficult to share. So when we ask practitioners about their barriers, we very rarely get close to the truth. If we use a theoretical approach to ask about those barriers, we're more likely to get to the truth. We give permission. So we get in the way of some of those cognitive biases. So for example, one cognitive bias might be fundamental attribution of error. So an example that I often give to explain this is if my dean says, Judith Dyson, brilliant job, you got that paper published, how did you do it? It's because I am a genius. I'm quite fabulous and I'm wonderful at my job. I am saying this tongue in cheek because you don't know me, I best say that. If she says to me, why didn't you get that paper published? Why haven't you achieved this? It's because I don't have time, the administrators are really rubbish, I've got far too much teaching to do, etc. So we kind of programmed almost to attribute undesirable behaviours to environmental or external factors. Another cognitive bias is automatic responses. So if you catch somebody in the process of doing a task with a patient and they haven't cleaned their hands and you ask them, then the knee-jerk reaction that often is said is, I forgot. You know, it is just that thing that we say when we put on the spot. Another cognitive bias is we give logical responses, those things that sound like they are true rather than the truth within us, if you like. So if we use a theoretical approach, we get closer to the truth on those barriers. So that's the first thing. The second thing we said we had to do was tailor our interventions. So if I just open up another box here, oops, I'm sorry, let me go back here. When we asked our people, what do your institutions do if things go wrong, if there's a never event, if there's an incident, these are the things that they tell us. They send emails, guidelines, they send training, they tell us what to do. But already you can say that telling people, giving what to do, or giving them training tends to influence our knowledge and our skills, and sometimes it can give us a bit of confidence. It's not going to help if we don't have staffing levels, it's not going to help if we're burnt out, it's unlikely to help if we're not very motivated. So whatever strategies we put in place, they've got to address those barriers. So we need to move beyond, and we're going to give some really entertaining examples towards the end of this talk from infection prevention examples. We need to move beyond training, and we need to tailor our interventions according to the problems. The final thing that I said on the last slide was then that we also need to underpin our interventions with theory. And I don't have a clever way of demonstrating that, but what I can say is that evidence tells us that if our strategies to improve practice and our interventions are underpinned with theory, they are 30% or more effective, so they work better. So they're the three things that we tend to focus on when we're talking about behaviour change for clinical practice. It's about understanding the barriers, using a theoretical approach to ask about barriers. It's about tailoring our interventions according to those barriers, and when we put our interventions together, making sure they're theoretically underpinned. And in the kind of next 35 minutes, we're going to whiz you through how we do that. So very quickly then, and I'm not going to linger, but I've got 2 more slides of theory before we move on again. How do we do that? So what we tend to do is we tend to rely on models of behaviour or behaviour change. So this is one, and this is the one that is the most frequently used, the theory of planned behaviour. There are others that you're more likely to have come across in mental health. I know we've got some mental health people with us, things like the trans-theoretical model of behaviour change, that pre-contemplation, contemplation, action, etc. So the first problem we've got when we're using these is that there are 33 of them, and there's absolutely no guidance from experts whatsoever. This is ASIN. Sorry, any questions in the chat, I promise we will mop up. Liz is taking note of them when I'm talking and vice versa, so I promise we will get to them if I don't see them as we're going along. So there are 33 models of behaviour or behaviour change and no guidance as to which one to choose. So what do we do there? This one is one of the most simplest in terms of its accessibility. So if I use my mouse to point, we've got attitudes, subjective norms and perceived behavioural control, which influences behavioural intentions, which influences the behaviour, in this case PPE use, and perceived behavioural control's got a direct link to behaviour. Now, when we talk about attitudes in common parlance, sometimes that kind of means, oh, they've got a bad attitude, they're a little bit awkward. In psychology, what that means is what we believe will happen if we do or we don't engage in a thing, a practice, a behaviour. Subjective norms is a little easier to understand as healthcare practitioners. It is about the influence of those and the environment around us, what is normal for us, what we think is acceptable. And perceived behavioural control is how much we feel we can influence our environment or people around us. And then intentions are, do we want to do it? Are we going to do it? And to what extent do we want to do it? Now, these things here, these 4 things are constructs in a model like this, and you can see there are 4. So if I was to tell you across those 33 published models of behaviour change, there are 128, it illustrates another big problem. Whichever model we choose, it's not going to be comprehensive. Now, I've said a few things about stress or burnout, and I've used that particularly as an example because oftentimes practitioners don't talk about emotion. Often in infection prevention, we know that people are more likely to clean their hands when there is visible dirt, or the ick factor, as we call it, which is an emotional response. But we don't tend to talk about emotional determinants in health, but they're there. They're very much there. This model doesn't touch on that at all, explicitly or implicitly, so we're going to miss things. Right, this slide then. This slide honestly could change all of our lives. So this is the theoretical domains framework and the references on the slides. And what these clever people have done, the work was led by Susan Mickey, and it included one of Liz and I's colleagues, Rebecca Lawton. They took all of those models of behaviour and behaviour change, and they condensed them into this one framework of 11 domains. And the whole point of them doing that was so that it would be accessible to us as practitioners, so we could use it to support our colleagues and ourselves in doing the best possible job that we can in clinical practice. Now, if I was to, and I'm going to, look back at what you said to us, I could pretty much, I think, categorise everything that you said in one or another of these domains. So the idea is, if you use these domains and some of these questions to ask people, some of the things I might not tell you, you give them an opportunity to say. So I didn't get a lot of emotional or motivational barriers on what you said. But if I was to ask you a few more questions, probably that would come out. That's normal human responses to a crisis like this. And, you know, we wouldn't be human if we didn't feel that sometimes. So going through questions on this, we will get closer to the truth of the matter, and we can do the things that are going to be properly supportive. Now, I'm not going to go through all of these because time's tight and they're fairly obvious. Knowledge, we know what that means and we know what skills means. Beliefs about capabilities is our confidence in our ability to do a task. Motivation, goals and priorities, how much we want to do it, how important it is amongst the other tasks we've got to do, and what we're trying to achieve. The environment, you guys came up with lots of things. Time we've already talked about. Beliefs about consequences is attitudes, what we think will happen if something, if we do something, if we don't do something. And that's not just about what will happen for our patients, it's us too. So will we feel bad? You know, that anticipated regret, will we get into trouble, will we be disciplined, will we take coronavirus home to our families? So it's what will happen if we do and we do it for our patients, with our colleagues and for ourselves and families. Emotion we've talked about. Social influences is a big one. I'm going to talk a little bit more about this when we talk about interventions, but we're so influenced by the people around us. And so many times have I seen fresh-faced young nurses, you know, leave programs of nursing and work in an area that we all know has perhaps lost its way a little bit, and within no time they've adopted those same heart-sink feelings as their colleagues. And equally, when we see nurses going to a high energy environment, how they flourish and contribute to that. So the people around us is really, we need to fit in. That's kind of part of our human state. Role identity, put very simply, it's not my job, or it is. Memory, attention and decision processes, simply put, sometimes we forget, but also if it's something new we're doing, we have habits and routines that we fall into, and building a new habit's harder to do. We've got to think about it consciously in action planning. Do we have a series of tasks that we're going to engage in to achieve where we're going? Now, honestly, this has changed my life. You know, all of you that are in management positions, try managing clinical psychologists is all I've got to say to you. But when we're looking after members of staff in a management context, or whether we're working with colleagues, or whether we're thinking about, you know, why our patients do or don't engage in health behaviours, the chances are that it will fit within one of these categories. And if you think through these when you're feeling frustrated that somebody's not doing what you think they should be doing for whatever reasons, you'll probably fall upon the solution yourself. There are some things that are not on here. The authors say that this is absolutely comprehensive, but it's comprehensive in terms of those things we can influence. So there are things we cannot influence. So for example, or we wouldn't want to influence. So somebody's religious beliefs. So we know that people with a Jehovah's Witness faith believe that people will be harmed spiritually if they get a blood transfusion. We would not want to change their beliefs necessarily. They're probably not attracted to areas where we do a lot of blood transfusions, but that's something that really we wouldn't ethically want to do something about. We'd find other ways of managing that, perhaps. Another one is personality, and mental health colleagues amongst us will know that we can change personality, and personality does evolve, but it takes a very long time. So there are some things here. This is Mickey. Sorry, I'm catching a few things on the chat, but the references are at the end and you'll get the slides. So we've got most of the references at the end. So when you're frustrated, another good example of what this doesn't capture, I've got 5 children and they've all gone through that hormonal stage, and what I will say is, however fabulous I think this is and other people use this, it's not going to work with your teenage kids when they're hormonal. So I'll put that on the caveat list as well. So of all the things we're going to say today, because there isn't time to do justice to this big subject, this is one thing you can take away when people are struggling to engage in the desirable behaviours, practice or otherwise. Have a think through this and ask some of those questions, and you will start to understand. When we understand, then we can start doing logical things about it. Okay. So, in terms of tailored solutions, then I'm going to throw it out there. I'm keeping a really close eye on time, and I'm sorry I'm talking so much, but I'm determined that we're going to go through all of these slides. So we'll try and be as interactive as we can, and we have got a couple more questions to ask you. But based on what I've said so far, then, if we take a couple of examples from what you've said, let me pick. Sorry, I wrote a list of things you were saying. So if we say you get flushes and the PPE is uncomfortable, throw it in the chat box. Just based on common sense, what sort of solutions do you think there are to that other than not wearing the PPE? I'll give you a minute. Everybody might be stumped. Or it might be taking its time to click on again. Go on, there are no wrong answers, have a go. I'm going to tell you, take a break, good one. More hydration breaks, change the uniform to a lighter fabric. Fabulous, you see this is fabulous. Now, one of the things I do when I'm working with practitioners designing interventions, look at ventilator options, medication to avoid hot flushes, I'm loving that one. HRT, I think we might be talking about there. Regular breaks, sufficient breaks. These are all fabulous, really, really fabulous. And this is why, and we're going to talk very briefly about co-design, checking we're wearing the right size gloves. We always have to co-design with the target group, the people that we're working with. And even when we're doing that, if you're embedded in that area, you sometimes get a little bit too close to see it. So it's often really useful to work with an external person, maybe somebody from your improvement contingent, as well as the team that's on the ground, or if you're an external person, because then you get the joy of objectivity and the experience of the people that are working there. And the one thing that I might think of doing in this improve engineering controls, what I was going to say was, often when I'm designing interventions with people, I get them to list everything, however wild, however unachievable it might seem. And it's surprising how, when you're going through that exercise, all the things that might seem unachievable become achievable, or we get so many answers that we can dismiss some of them and focus on others. One of the things that I might want to do in this situation is put a notice on the office wall with pros and cons. And on the cons, that would be the discomfort, because oftentimes people, their behaviour is determined by the instant gratification or the instant pain rather than the longer term reward. And just doing an exercise like that can just remind us of how uncomfortable it is now, but how useful it is in the longer term. Okay, so let's move on to the next. Oh, let me just ask one more thing, one more example. You've got somebody that you're working with that's just totally stressed out. They're so stressed they can't even think. Their family's got COVID. They've been cooped up in a care home or in a, you know, they're being called in all the time because there's not enough staff. What are you going to do about that? Have you got any ideas for that? Giving feedback is a good one for the previous example and this one. Do you know what? Saying well done or thank you goes so far in keeping people, time to listen to them, time off, brilliant. In the olden days, we'd take our mates to the pub, wouldn't we? Or give them a call, or send an email to somebody saying, I really admired you when you did that. I really, you know, I noticed that you did that. Thank you. Well done. Those little bits of appreciation can go such a long time. Empathy, acknowledging how difficult it can be, showing appreciation, taking breaks together, listening, fabulous, absolutely fabulous. And we forget, don't we? We get caught up in our own houses, or we're so busy when we're in practice that those things can sometimes be missed. Positive role modelling is massive. All these things that you're putting in now, we're going to come back to again in a little while. These are fabulous. These are really brilliant. Right, now we're going to come back to it now. Now, we can't tell you much about this because we don't have time, but I'm just going to tell you very briefly. So one of the other absolute benefits of that theoretical domains framework is if we categorise the barriers according to each of those domains, and if we go back, let me categorise some of you. So comfort and fit, and the right size would go in environmental. So it's kind of, oh, I can point, can't I? Here we go. It's kind of part of the environment. Training or no training might be about a lack of knowledge, or it might be about lack of skills. Time would be environmental. It's complex, that could be about knowledge. Not understanding why it's important would be beliefs about consequences. What will happen if we do and what will happen if we don't. And flushes, the equipment itself would go in environment. Because the boss says so would be social influences. This isn't the way we do it here, would be social influences. Right, so let me get back to this. So one of the advantages, now you guys have come up with great solutions based on common sense. So just from that one TDF slide, you're kind of thinking about how you can tailor your solutions according to what the problems are. But the final thing I said, the third thing, was that we have to underpin our interventions with theory. Now, how we go about this looks complicated and it's referenced. It's not complicated, and part of the reason I put it here is to demonstrate how easy this is. There are a list of behaviour change techniques. Now, this is a list of about 30, I think. If you look at the paper itself, there's 44. There are 163 behaviour change techniques in total. Why I like this particular grid is these white squares means in this circumstance, this has been proven by loads of research to work. Now, I've just circled 2 to demonstrate how easy this is. So 2, as you can see from the key, is knowledge. And it's typical of researchers that when we go back to the TDF, 1 was knowledge, and here they've muddled it all up. But anyway, it's written here, is knowledge. So if we scroll down 2, we're looking for a white square, because white squares means it works. Here we've got a white square. We go left, information about the behaviour or the outcome. Now that's obvious, isn't it? That's really easy. If we go down 3, there's lots of white squares, but I've just picked on 1. 3 is skills. So if we go to this one and go to the left, rehearsal or practice, we all know this. People like us that have worked in health know a lot of this intuitively. And I bet when you leave the session, you're thinking, okay, you know, I get how that can be applied, but actually there wasn't anything said there that I didn't already know. And that's a good thing. Because we learn these things through experiencing life and experiencing giving care the way we do. Now, again, time prohibits us from going down this list. But if you go down this list yourself, you will find very few that as a healthcare practitioner you can't interpret or you don't know. That said, on the link that Liz showed at the beginning, in our toolkit, we've got definitions for all of these definitions. So monitoring, that's like our hand hygiene audits, for example. Contract, tell someone you're going to do it, you're much more likely to do it. Rewards and incentives, you know, even saying well done, you know, that kind of internal reward, and so on. Prompts, triggers, cues. One thing I'm just going to draw your attention to, because when I was a student and whenever I go on any courses, one of the things I hate is role play. And if you look across here, look, there's no white squares. It won't change my behaviour or your behaviour. Simulation's a bit different, so I'm not dismissing that. But for those people that don't like role play, this reference is a good example of how you can get out of it. Right, we're at a point where we are going to tell you one more thing, but this is a good point, I think, for us to just pause for a moment and ask if there are any questions or comments. And I know Liz has been noting a few down, so Liz, feel free to shout questions out or answer questions, and by all means people stick your hand up so that we can see you asking. And any questions at this point? I'm just scrolling up for questions too. I'll give you a minute just in case there's anything you want to ask. And yeah, we'll provide the references and the theory. We don't get rewarded for compliance. Okay, I'm going to move on in that case. Right. So in some ways, we're turning this session completely upside down. So the first thing I'm going to do is give you some examples of interventions that other people have devised for infection prevention and control. And then we're going to go right back to the beginning, and we're going to give you 1 second tip that you can take away today from all of this complexity that you can use immediately. And again, it's something that you know, but you probably are so embedded as we are that you won't realise. So firstly, let me just tell you a few stories. Sorry, I can see there's more messages. Teams is so impersonal, isn't it? Here we go. Right, so these are things that we've come across before. These are things that people have told us in different workshops, or we've collected. These are things about infection prevention because of what we're doing today, but between a group of us, including Liz, we collect these like magpies. So if you've got great examples, let's have them. So talking cones, and I say that very carefully because I'm from Hull, and if I don't enunciate you won't understand what I'm saying, but it's on the slide and very often I have to do the actions. So in intensive care in Hull, outside the door during the peak of Clostridium difficile and MRSA about 2007, they had traffic cones that were, when you walked past them, they were activated and they said, please don't forget to clean your hands. Now that is a prompt, so if somebody's going to forget or they're not in the habit of it, that would prompt them to do it or remind them. So if the barrier was forgetting or they're on automatic pilot and they don't usually do it at that point, that would be an intervention that would work. In Harrogate, anyone that's come across Kath Banfield, the Director of Infection Prevention Control there was that particular year or the year before, she'd had the hospital choir record MRSA lyrics they'd made up themselves to the song YMCA. Now, I won't ask Liz to sing it, and I hope you all know it because I'm not going to sing it either, but that YMCA Village People song. And again, if we needed to raise awareness about the importance of this, that would be a really good strategy. But we need to remember posters or anything like that that's there all the time, we become desensitized to, so we stop hearing them or seeing them or noticing them after a while. So anything like that needs to be changed regularly. In Leeds, they had a certificate and an extra day's annual leave for somebody who was nominated as the hand hygiene champion. And again, that goes, so I don't suppose any of us would really appreciate a certificate for hand hygiene. It's the appreciation and the acknowledgement and the recognition and somebody saying well done that kind of that makes the difference, and that would have a real effect on increasing motivation, because that's a behaviour change technique that motivates us. It kind of increases our internal motivation. In Airedale, I worked with a group of FY1 and 2s, and they said, oh, if sister tells us to, we do it. So those of you on the call right now, if you're a ward sister charge nurse, please understand that your power is more than you could possibly believe, because I couldn't have believed this from them. So when we designed the intervention, we basically got the ward sisters and those people that were accompanying the ward rounds to prompt, and it was done. It made a big difference in terms of compliance with hand hygiene. Now, this is something that I got from a paper, and actually one of the authors on this paper, the key author was Judah, and Susan Mickey was one of the other authors on this paper, and I just loved it. So basically, during an epidemic in a country, I can't remember where, they basically decided that social peer pressure was the strategy they were going to use to try and increase hand hygiene amongst members of the public. So they basically put up one of those boards that goes round and round and gives a message. I want to say above the urinals, it was probably above the toilet doors now, as I think about it, saying, will the person next to you clean their hands? And soap usage went up fourfold. I mean, one of the points I'm making here is your interventions can be really quite, as long as they're clever, they can be really low cost and impactful without taking up a lot of time or our effort. And I'm just going to tell you about one more before we move on to the final point that we want to make, really. This is the accidental intervention, I call it, and somebody called Jo from Doncaster told us about this. She was working in a medical ward, I think, but she was basically looking after people in a 4-bedded bay on this particular occasion. And one of the patients said to her, can you just come across? I'm really quite worried. And said to Jo, I'm really worried about that woman in the opposite bed. Whatever she's got is really infectious, because whenever any of the staff go to her, they're cleaning their hands at the sink, then they're putting gel on, then they've got gloves on, they've got pinnies on, the whole shaboodle, then they do it all again. She says, I've never seen people clean up so much with her. I'm really worried that I'm going to get whatever she's got. The woman in the opposite bed was the director of infection prevention and control at the time, which kind of gives us a good indication of how the social influences can impact on our behaviours. Okay, before we hand back over to you again with another question, going right back to the beginning, one of the things, one trick, and you'll start noticing this now if you haven't already, because, you know, somebody, you know, I've been a registered nurse for over 30 years and I still go out in practice. It's important to me to feel that I am part of practice. And I never noticed this. The first thing that we have to do if we're going to influence practice behaviours is tell people what we want them to do. We need to define the behaviour, and we need to be as specific as we can without being overcomplicated. And believe it or not, we do not do that. So let me just tell you what we do. What we tend to do is we give our practitioners goals, what we want them to achieve, not what we want them to do. The minute we start bringing doing words, verbs into the conversation, the chances are suddenly practice will start to improve. So for example, in diet, the goal might be to lose 3 pounds, but the behaviour might be to eat more lettuce or to eat less chips or to move a bit more, for example. A patient safety example, then, or a clinical example, the goal might be to reduce wound infections, but the behaviour might be to give prophylactic antibiotics, or it might be about hand hygiene before the aseptic technique or something else. So oftentimes you'll see goals but not behaviours. The one exception to that is the patient safety alerts that we used to have, and every time there was an ever event or similar, a patient safety alert would come out. It'd be about 2 pages long and it would tell us what we had to do. And very often there was one, some of our colleagues did a big piece of work about nasogastric tubes and checking that they were situated correctly. And basically the answer is use the litmus paper, the pH testing paper. X-ray is an absolute last resort. Because things go wrong when people go for x-rays, they look at the wrong x-ray, it gets dislodged in the movement of people and so on and so forth. That was really all they were telling people to do on this patient safety alert, but when we counted them, there was something like 37 behaviours. So sometimes we're kind of overcomplicating it, but most of the time we're giving goals and not behaviours. Oh God, there's nominations for hand hygiene champions going on in the chat. So let me give some examples. Now, and I'm not going to get you to do this just because of time, and we want you to do something on the next slide, which is more important. But when we ask people in our workshops to give us the answers to this, often they get this wrong. And this demonstrates to us how unused we are to behaviours rather than goals. So is it a behaviour, is it a goal? For patients given a non-steroidal anti-inflammatory drug, also give a protein pump inhibitor. And that's a behaviour, it's doing words. And I cannot tell you how hard it is for me to get these terms right as somebody who spent most of my career in mental health, and now I'm kind of, you know, teaching students most of my day. Reduce risky prescriptions by 20%. It's a target, it's a goal, it's not a behaviour, it doesn't tell us what to do. Reduce inpatient falls, goal. Carry out a risks fall assessment for every patient within 12 hours of admission. That's lovely, that's a behaviour. Use a certain checklist with every behaviour again. Improve pressure ulcers, goals. So the second thing, the TDF that's on a previous slide, that's the first thing that's a real good takeaway from this session. The second thing is this: make sure people are told what we should be doing, not just what we're seeking to achieve as an institution. Okay. So I wondered, we've got 2 tasks for you now before we close, and we've got 7 minutes left. So is there anybody that wants to share with us, using this slide, and will help, a PPE problem in their area? So stick your hands up. I'm going to keep talking while I'm looking for your hands. Come on, be brave, be brave, be brave. So when we're talking, so in your areas, if you're talking about PPE use, all right, I'll talk, but put your hands up if you, oh, somebody's offering. Okay, who is this? Chrissy, go on, Chrissy. Tell us your story. What's the problem with PPE in your place?
Well, I support the care home. And one of our care homes, the manager doesn't seem to be a good role model and doesn't seem to get it and just say, oh, well, I haven't got time to do that. And it's quite an issue, really, because, yeah, she's not a good role model for her staff. She's not practicing good donning and doffing. And when her staff aren't doing it properly, she's not sort of challenging and explaining why it might be done better. And when you sort of speak to her about it or try to show her, she says, oh, well, I know, but I'm not going to do it that way because I really haven't got time. And it's quite a challenge.
Sorry, Judith, you're muted.
Thank you. So sorry about that, Chrissy. So what I was saying was, what you've done, Chrissy, is you've gone straight to the barriers. So PPE or whatever practice, probably a lot of practices given that barrier, and not being done optimally. And the reason they're not being done optimally is because this person is not a good role model. Now, I can't linger with that example because the interventions to address that would take a really long time. Chrissy, come on our programme afterwards or email me, and we'll have an email chat, or I'll catch up with you. So that is a brilliant example of a barrier, a really, really fabulous example of a barrier, and a big barrier that is really hard to address. And those sorts of barriers sometimes take quite a long time, and put very quickly. I mean, you've got your disciplinary and your capability procedures, which take forever. But actually, if you pull a team together to do something despite that sort of climate, that's another strategy as well, if you've got a really good team. But in terms of the behaviour with PPE, go on, Chrissy, did you want to speak again? Or is that a
yes, sorry. It's just to say that because we're sort of health board and we're visiting the home and it's a private company, you can't go down those capability routes in quite the same way. So that makes it, you've got to really get that person on side. And yes, that's the challenge for me.
And you can do that, you know. I mean, as we said at the beginning, nobody comes into this job to do a bad job. So what it might be worth doing, Chrissy, before kind of looking at answers to this, it might be worth going back to that TDF and just making time to sit with her and have a chat with that TDF, that theoretical domains framework, in your mind, and to ask her some of those questions. How is she feeling about her job? What frustrates her in terms of the emotion domain? What frustrates her about her job? You know, what are the priorities in her home at the moment? And once you get a better understanding of why she appears to have that low motivation, it might be an easier one to address, but it's a complex and difficult problem, but it is doable. It is doable. Going back to the behaviour then, if anybody is thinking of coming on the programme, the 4-session programme after this, and making big changes in practice, think about what the problem is. Who is it? What group of people? So is it the doctors that are struggling with this particular thing for some reason? Is it the care assistants? Is it the bank staff? Is it everybody? So think about who it is. Think about where this problem occurs. So if it is about PPE, is it, as people were saying on the chat, you know, when people have got dementia and they're confused and communication becomes difficult, is that the nature of the problem when this happens? And you know, is there a particular area? So is it when we go into the dressings room, or is it in the loos, or is it when there's an emergency and it's not available just to grab or something like that? During any particular procedures, is it a time thing? So during the night this is a problem, and specifically what is it, you know, what are people not doing when? So the first thing to do before any improvement project is be clear, first of all, what are the problem behaviours, what isn't happening and what should be happening, and if you possibly can, capture it. How do we know? Hand hygiene is so easy, isn't it? Because we can observe it, or we can measure soap usage or something, but this is very much more difficult. Now we've got one task as we go out and as people are saying goodbye, but let me give you one last story before I hand over to Liz for the last task and then the close of the session. I work with a lot of practitioners, and sometimes I'm lucky enough to publish with them, and I was working with a guy, Morris Madia, for infection people that might know him. And they had a trial of a hand hygiene prompt and monitoring system, an electronic thing where you went under sensors and you put your gelled hand in front of it or stood under a sink sensor, and it recognised you'd cleaned your hands. Compliance apparently went up loads. I did some interviews with practitioners and asked them about it, and they were just cheating because they hated it. They thought it was patronising, which I agree with. You know, it was undermining. And what they do is they pull the little tag out so it wasn't monitoring. Or one nursing assistant said to me she'd gel her hands and then she'd help everybody out by gelling their badges to look like they clean their hands. Or somebody put it on top of the dinner trolley. So when they're going in and out of rooms, it wasn't registering that they should have cleaned their hands as they went into all the side rooms. So the moral of the tale there is, when we're putting together interventions to support a particular practice, it's got to come from the practitioners. It's got to be that bottom up frontline practitioner that comes up with and contributes to the problem, not some company or other being that's just trying to sell a device. Okay, I'm going to hand over to you, Liz. Are you with us, Liz? You might be on mute.
I'm not on mute anymore, thank you. So hopefully there'll be a few of you out there who felt like I did when I first went along to one of Judy's sessions. You know, it was like there was a light bulb that went on for me, and I could really see where I'd often struggled in the past. So, you know, putting up posters or providing more training, you know, why that really didn't actually make a difference. And the fact is that actually there was evidence out there that could help me find better interventions that could work for, you know, any of the problems that I might come across. And I use this so much in pretty much all the projects that I work on now. For those of you that you know, feel excited by this or want to learn more, we're offering you the chance to come along to do a virtual training course and coaching program with us. It's run under 4 short sessions, and what we do is help you, guide you through a project, and take you through all of that. Okay, so there'll be information emailed out to you about that at the end. And then the last thing that I'm going to ask you to do is, if you can, for those of you who are still with us, please pop in the chat what your pledge is. You know, is there something that's really struck you during the session that you want to take away when you get back to work, or finish the session. So, you know, is there, you know, could you identify a stressed colleague? Is there some of the things that we'd mentioned that actually you could do that for that person, take a break with them? I liked one of the advice was a hug in a box. I don't know what that is, but I absolutely love that idea. Is there, somebody mentioned about the fact that there's no reward for compliance. Is there something that you could do about that to help reward people? That's something that came across quite strongly with some work that I've been doing recently. Is that, you know, people are trying really hard to do the best, but there wasn't a lot of recognition for that. If you're worried that you're not doing it properly, could you find a buddy to help you and have a practice at putting PP on and off, donning and doffing? So those are the kind of things. So please pop them in the chat, what your pledges are. And then you just want to share the last slide, Judith. And then the last thing that we'd like you to do is we have an evaluation link for the session. We'd really appreciate your feedback. So there's a link there, and again, this will be emailed out for everybody. So I understand you're really busy and we really appreciate you taking your time out today, but it'd be great if you could just spend a couple of minutes filling that in for us. And then the very last slide we've got is just our references.
That's great. Liz, thank you so much. I just wanted to finish off saying a huge thank you for everyone for taking the time to attend the session and your active participation. All that's going on in the chat is absolutely fantastic to see and share. Wanted to say a huge thank you, Judith and Liz, for doing the session for us, and for Mandy for the introduction. As Liz has said, we will be sharing the resources. Please, can you complete the evaluation? Really important for us. We will also share the slides, and as been mentioned, if you're interested, there is a further online course that we're looking to start in February, and we'll be sending out the information for that and how you can look to apply for that. So practical course, and I think this session has been packed with tips and a very practical application for practice. That's what the course will be, allowing a bit more time and detail with some coaching support for teams. It will be hosted and funded by Improvement Cymru. So if you're interested in gaining a place, we'll share the information so you can apply for that. And also just to say from Improvement Cymru, we've got Lisa, Fab and Rupert Leslie on the course as well that we'll be supporting. So just wanted to say a massive thank you to everyone. Thank you very much.
Thanks, everyone. Bye-bye.
Bye-bye then. Thank you.
Thank you.
Thanks a lot.
Thank you.